name's Andrew Coates. I'm Scientific Director and CEO of the Heart Research Institute. I'd like to welcome you to a fantastic heart-to-heart seminar tonight. First of all, I'd like to pay my respects to the elders who look after this wonderful lab, the Gadigal people of the Eora Nation. Pay our respects to their elders, past and present. And of course, we pay respects to all Indigenous communities and elders throughout the nation. Heart Research Institute, as you know, is dedicated to investigation and treatment of heart disease and blood vessel disease in all its manifestations. And it's actually a very broad range of separate processes, a remarkable difference between what happens to blood vessels, to the heart, to the brain, to the legs, as well as different diseases that affect the heart itself as the central point. But we have 14 research groups really growing, and we're constantly recruiting new people because there's ever more to do, and they really have a diversity of activities. But tonight we have the great pleasure of hearing from one of our proudest group leaders, that's Annemarie Hennessy. I won't steal the thunder. Katrina's always upset that if there's a little just because she didn't introduce. But the Heart Research Institute is very proud of its supporters, its colleagues, its network. You are what we're here for. We had a little strategy session about 18 months ago, I think. It was, what are we aiming to do? There was lots of highfalutin statements about preventing cardiovascular disease, reducing mortality. But it boiled down to, we're here for you. We're here so that people don't have to suffer, don't have to lose relatives at a very young age. We're here because we want to help the community make a difference to cardiovascular disease. And there are many manifestations. Tonight, you'll hear, is one of those that probably shouldn't be a problem, but it still is. But Annemarie Hennessy is absolutely one of the leaders in the world in the field of preeclampsia research. And I think we're really looking forward to it. But I'll hand over now to Katrina, who'll take through the wonderful format we have for these evening seminars.
Thank you, Andrew. Thanks for that great introduction. And good evening, everyone. And thanks for joining us tonight for Heart to Heart. We're really pleased that you've made the time to join us. A warm welcome to those of you who are here in the room with us tonight, and to everyone online as well. We've got a lot of people who have joined us online. By way of introduction, my name is Katrina Dowling, as Andrew said, and I lead the Development, Philanthropy and Communications team within HRI. And we're really pleased tonight to be joined by you, Annemarie Hennessy AM. You are the leader of HRI's Vascular Immunology group. And your research aims to understand the causes of preeclampsia, how preeclampsia affects women during their pregnancy, and importantly, the impact for them in terms of their longer-term cardiovascular health. So thank you, Annemarie, for making the time tonight. And for those of you who are joining us for the first time, as Andrew said, HRI is an internationally recognised medical research institute, and we have a single focus on researching the causes and the complications of cardiovascular disease so that we can develop better diagnostics, treatments, and ideally cures. We were established 35 years ago, or over 35 years ago now, in 1989, to fuel both basic discovery research and translational research. And today we're comprised of 14 distinct research groups, stretching across our location here in Newtown and at the Charles Perkins Centre as part of the University of Sydney. So the team is focused on delivering cutting-edge research, and as an organisation we have a commitment to nurturing the best and brightest minds, the next generation of researchers, the rising stars in cardiovascular research, and we're also committed to facilitating opportunities for women building careers in science and research as well, and to better understanding how cardiovascular disease affects both men and women. So this is particularly relevant for our conversation tonight, as Annemarie is a senior female research lead within HRI, highly respected within MRI circles, and not only an advocate for other women developing and mentoring future female leaders, but your work is also directly focused on better understanding the impact of cardiovascular disease on women. So why do we as HRI exist, and why are we doing the things like tonight? Put simply, coming out of the strategy day that we held 18 months ago or so, we recognise that the core reason why we get up every day is we want more people who are impacted by cardiovascular disease to have more time with the people that they love. So that is the way that we'll start tonight. So let's get underway. So I'd like to formally introduce Professor Annemarie Hennessy. Annemarie is leader of HRI's Vascular Immunology group, along with Professor Angela Macris, and she's Deputy Dean Westmead for the Faculty of Medicine and Health at the University of Sydney. So you've previously served as Dean and Foundation Chair of Medicine at Western Sydney University from 2006 to 2023. And Annemarie has over 30 years of experience in preeclampsia research and is actively involved in clinical and laboratory research into the causes and treatments of high blood pressure during pregnancy. So you direct and develop and mentor a lot of PhD students at the Heart Research Institute, the University of Sydney and Western Sydney University as well. And you're director of PEARLS, the Australian Pregnancy Hypertension Foundation, along with Amanda Davidson, who we thank you, Amanda, for joining us tonight, who has worked with Annemarie for many years in the capacity of consumer advocate and a terrific supporter of your work. So thank you. So we might get underway with some questions. Annemarie, tell us more about why you chose to pursue a career in medical research, how your career has developed over the years, and what motivates you to keep pushing for new discoveries in terms of medical research.
Thanks, Katrina. Thanks, everybody. I have got a bit of a cold, so if I have to stop for a cough, please excuse me. But thank you all for being here. Cold, wintry night. And I also would like to just start by acknowledging that we're on the land of the Gadigal people of the Great Eora Nation, and acknowledge any of our colleagues who are of Aboriginal background here with us today. That's a great question. I've never been quite asked the question in that way. Why did I choose or seek a career in medical research? And I think my answer to that is that it chose me. It didn't go the other way. That one of the first conditions that I looked after on a remote Aboriginal community in North Queensland when I was working there, it was a beautiful Boogalman woman who came back to the island of Palm Island where I was working, having been sent to the city in her first pregnancy because we didn't have enough facilities to deliver or to assist those women with their birth on country. And I must admit, in those days we didn't even speak in that language, but she made it very clear that she wanted her baby born on country. So she rowed herself back out to the island, which was 18 kilometres off the coast, and hid in a cave until she went into labour. So she'd been just 37 weeks pregnant when she was sent back to Townsville, and she rowed herself back to the island. And I got this call from a very frightened midwife at midnight saying, you need to come, and you need to come, and you need to come now. And that's not a comment that she would have ever made to me. And this young woman had fulminant preeclampsia. And I remember ringing the senior doctors in town. I was very junior at the time, and said, I've got a woman here with severe preeclampsia. Can you send a helicopter? And they said, no, she's going to die. It's a waste of time sending the plane. And I said, over my dead body. So I actually rang the health minister that night and said, you will send a plane and you will do it now. For someone who was that junior, I did get a bit of a, I didn't. But so we did. She survived that. So it was a condition that I had seen at medical school, and was confronted as a solo doctor, and with this notion that it wasn't worthy of saving. The next step of my career was to become a physician, and I ended up at RPA in Australia. At the time I was offered at that job, I couldn't spell RPA, but I came there and off I went from North Queensland, and landed in a group of physicians who were studying this disease that I'd seen, preeclampsia. So I partly chose my pathway as a renal physician because it just so happened that the preeclampsia research team at RPA at the time and as now, happened to sit in that department. If I'd gone to Brisbane, as the expectation of my family was that I'd have gone there for my training and I'd found my path into preeclampsia, it would have been under cardiologists, which might have been a better fit for you in a way. So it kind of found me on that journey. And now, since that day until even last night, caring for another family who are second generation being impacted by preeclampsia. I've looked after 15,000 women as a clinician with this condition. And Amanda and I met in that journey of me caring for Amanda as part of her care team 24 years ago, but have been driven by the science that we need to make the life of the women that we see better, and have become, of course, in more recent years, much more aware of my capacity to contribute on a global scale to ways that we can recognise, identify and potentially treat this horrible disease that we know the impact of it. I don't think we can make it go away, but the impact of it we know we can reduce, because it's actually, you know, the safest place in the world to have a baby is in Australia or Estonia, it turns out. Their maternal mortality ratios are 2 women who die at birth out of 100,000 women, whereas there are places around the world where that figure is 400 to 2,500 women per 100,000 deliveries. So we know that if you get the care right, and I'll talk you through all the things that we can do to try and contribute to that, we know we can achieve 2 out of 100,000, and we should be able to do that by the way we identify, find causes, identify those causes, you know, make an appropriate timely diagnosis and assist the mother with a birthing plan that ends up with a live mother and a live baby. So that's the motivation.
Interesting, great, thank you. And can you tell us a little about preeclampsia? What is it? What complications does it present, both during pregnancy and beyond?
Yeah, it's a funny word, isn't it? I found 17 countries in Africa don't even have a word for preeclampsia. So they use the kind of words that are the scary words. When I ask them to tell those women in language what preeclampsia is, they say it's fitting in pregnancy, it's epilepsy. No, it's not epilepsy. It's swelling in pregnancy. Well, lots of women get pretty swollen. It's a headache in pregnancy. Hands up if you get headaches all the time. You know, that migraines are really common. It's a kind of migraine headache. It can be quite different, but it can be non-specific. Amanda has talked to me a lot about a symptom checker, given how ubiquitous some of those symptoms individually can be. You know, how do you add them up to know which is the woman who's got a problem with her pregnancy or not? The classic diagnosis is a mum whose blood pressure goes up, and so that's partly why renal physicians and cardiologists work in this area, because we know about blood pressure. I find blood pressure fascinating. And their blood pressure goes up suddenly screamingly high, and they start leaking protein from their kidneys. And in my days on Palm Island, if I wanted to diagnose the protein, I just boiled the urine, because like an egg, it's like egg white, it goes solid when you put it over a flame. So I just boiled the urine, and as it became more solid like an egg, I'd go, I think we've got one. I didn't have a laboratory anywhere that I could send things to that I couldn't get a result for days and days. So I've never ever heard a mum out of my 15,000 or more say that they've noticed that their urine was frothy, but that's what you might have noticed back in the day with a lot of protein in your urine. It goes, it's gross to talk about after your snacks, but that it goes a bit. But one of my sons one day used to sit in the rooms, and the mums would come and see me, and they'll hand me a yellow jar. And he was in grade 1 at school, and someone said, some people collect stamps and leaves, what might other people collect? And he said, I don't know, my mum collects urine. So don't keep it. Just so this urine protein can be tremendous, you know, for about 2 or 3 days. You suddenly deliver the baby, we thought, but actually turns out that you need to deliver the placenta, and of course the baby can't survive without the placenta. But once the birth has occurred, you see that protein go away within 2 days. Very bizarre. So the word preeclampsia stands for the Greek for lightning strike. It can come very suddenly, and that really pertains to the seizure. So you might think things are going along okay, and then you find the mum fitting. And those fits usually only last about half a minute, but they can be life-threatening. And know immediately that you need to deliver that pregnancy immediately for the fitting to stop, and for all the consequences of that seizure to go away. So that's kind of where the words come from. I did say to a mum recently, you know, it comes from the word for sudden, and we're watching carefully. She said, but you know that the storm's coming because you can see the storm, which I thought was a lovely analogy. And we have got better at saying, and we'll show you that data that we've been working on, how can we get better at predicting that the storm's coming, and is it going to be one where there's lightning striking or not? So that's... Yeah,
which kind of leads to my next question, which is how do we test for preeclampsia? How do we see it as it appears? And how do we monitor it best?
Are we able to move to the slide with the test on it? Because that might help you. So we have got a slide showing, we used to tell everyone about Kim Kardashian, but now we can blame Meghan Markle because she finally revealed in her book she had it as well. And I've got that slide there just to see what we see all the time, which is a mum that goes from a slender appearance to suddenly being very blown up. Kim Kardashian's feet were actually published first, and her shoes were biting into her ankles because there was so much swelling in her ankles. And if you have a look at little Megan's face there, I don't apologise for stealing that photo from whoever Getty Images are, but have a look at her face. She's barely recognisable as the same person. And one of the things I often do with the mums is say, can you show me a photo of your face 3 months ago? And that they're almost, you know, round the eyes, but that sort of overwhelming puffiness. But we don't want to wait until all of that disaster that we've shown you there happens, the liver problems and the seizures and the swelling and the kidney failure, which comes with all of this. We want to go to getting a blood test that will tell us that this is coming. So on the next slide, we'll just go to the one before, just so it's got its name there. It's complicated. We say in Australia flat one, the Americans call it flit one. We have a fight about that. But we fundamentally found that the placenta makes good things and bad things. We've known for 6,000 years that it's a toxin coming from the placenta. Our work and others have identified that this toxin is this thing called flat one, FLT-1. And you need to make small amounts of it to have blood vessel integrity, and some parts of it are not free floating in the bloodstream. They're attached to the cell wall, and they're important to how blood vessels work normally. But once it starts getting poured out from these dangerous placenta and starts to bathe the blood vessels, they go into spasm, which is where the high blood pressure comes from. They deeply damage the kidney, so it leaks all this protein, and they're the first two markers of what is a pathway towards this mum getting very unwell very quickly and potentially losing her baby. But its job is to balance placental growth factor. So that's the healthy growth factor. So we were able to show that healthy placentas make good amounts of placental growth factor, and once they start to get toxic, they make really high amounts of this toxic bad compound. And the more of that you make, the less able it is to make its good factor. So the placental factor goes down, the toxin goes up, and if you have a look at the ratio of those, one's going up, one's going down, you can detect mathematically quite quickly when then that placenta's in trouble. Because these factors are now very clearly identified as coming from the placenta, they're easy to measure. We've started measuring placental growth factor very early in the pregnancy. If we measure that at 12 weeks at the same time as check the ultrasound of the baby and have a look at some of the other characteristics of the pregnancy, you can actually be given a score of your likelihood to get preeclampsia. So one of the commonest phone calls I get from women all around the world is, my ratio is blah, what am I going to do? So what's the point of having a test if we can't fix it? So part of our lab group have looked at, when we get this data about that early risk and profile, can we put something in place that diminishes the chance of that converting into at least the very serious form of preeclampsia, but ideally, as Andrew says, how can we just not have it at all? And so with Amanda's help, we recently designed a study where we're attempting to get funding to try and do the test regularly, maybe even monthly in the pregnancy, rather than waiting till things start to come unstuck and the mum's starting to get a bit sick. Amanda says to me, why do we have to wait until this woman's got a terrible headache and is feeling lousy? If it's obvious preeclampsia, you don't even need the test. But what about when we're on the pathway or the road to that journey? And so this test has been confirmed by our lab as being very specific to a sick placenta. And that is now something we're using in routine clinical practice. So at the moment it's analysing the first 4,500 patients in southwest Sydney and Sydney where we've used this test to try and help us establish not just the diagnosis, but how much baby support the baby's going to need, and what's the chances of the mother getting out quickly, and being well as a result of the pregnancy. So when we talk about the test the rest of this evening, I'm talking about that. So we'll give you an extra prize, an extra Peking duck roll, if you can say that at the end of the talk.
And how do we monitor and address through the duration of pregnancy?
Well, the way we get I talk about maternal mortality ratio, which is how many women die. Isn't that an awful thing? And I wish that had gone. But also our stillbirth rate is much higher than it should be. How do we get it as low as it is in Australia? And that's because we have high quality healthcare, and we have great science in Australia. We have some of the best preeclampsia researchers in the world in Australia, and that infuses the way that we think about what we do. That's why HRI is so important, its relationship to the university and to the hospital. We think of a question, we see a mum who's in trouble, we come down here and say, have you got the tools or the people who can help us work out how to solve that problem? That's exactly what I did, and HRI has been a very happy home for me, with people who can help me do everything from analyse the blood pressures, to think about how to grow the blood vessels, to think about how to stress those blood vessels and what to do with them. I've been challenged recently by the ethics committee about my right to keep and use placentas that women have donated to me to our lab group over the last 27 years. And I did respond to them today. They don't have a problem with us doing the work, it's just the way the paperwork works. Blue form, pink form, I say, let's get the paperwork right. But those women would be more offended to think their placentas, I think, weren't being used, because the number of times we've been able to take a mum's placenta with preeclampsia, a normal placenta, and say what's different, what works. The Institute's given us the power of the tools to do that. We can grow bits of placenta, we can test them against drugs that we're interested in, and out of that process comes a pathway to great care, which the hospital provides, but great scientifically balanced care that comes from the kind of questions that our team, and I'll show you our team shortly, are asking every day, every moment of every day, out in the clinics of Sydney and beyond.
Okay, and so I understand that you've made some really novel discoveries in terms of the use of aspirin and other things in treating preeclampsia. Can you tell us a bit about that, and also talk more about the concept of placental growth factor as well?
Sure. So we thought this good growth factor, that was one of our dead ends, and I am going to talk about that actually. I wasn't going to, but I think I will. This good growth factor, the placenta should make it, and if it makes good amounts of it, it should have a good pregnancy outcome, what we call a normal pregnancy outcome, born at term, a good weight baby with a well mother. That seems straightforward. So we did a set of experiments in our human placentas where we started to add more and more placental growth factor. So if it was good, would a bit more be better? Didn't turn out to be. What we did was try to stimulate those little placentas with bits of aspirin or calcium or garlic. We even tried garlic. We did other things to see if we could make that placenta make more placental growth factor. And surprisingly, some of the simple things like aspirin could show a difference. One of our researchers, Katrina Chow, and I'll mention her specifically because she got elevated to associate professor yesterday on the back of the work that she's been doing, and she rang me at midnight. What we did in some of her work was we tried to establish the preeclampsia and then see if the placental growth factor could then rescue things and make the placenta better, and that didn't work. So what that tells us about the placental growth factor is it's a signal of how well growing the placenta is. So we need to do other things to make the placenta grow well, and that's why we've tracked back to aspirin and calcium, because they stop any little blood clots or any little problems with the placenta growing well. And if you get that right, it'll make its own PLGF or placental growth factor, and we want it to be able to demonstrate to us that it can do that. The stronger the PLGF, the less likely it is to make the toxin, and the chances of growing that toxin out of the placenta are what we want to stop. So one of our key findings in the negative has been that you can't rescue this, you've got to get the placenta right, so we stopped trying to do that. What we have been able to show though are the reasons why the placentas make this toxin. So we didn't discover soluble flat 1, although we were very close. I had been started working on this when I was in New York in Cornell before I came back to Australia. So we were sort of close, but others discovered the compound. What we were able to do, because of the depth of our clinical connections, were to show what it is that's going wrong with the placenta and why it's being made. And that biological plausibility stopped us testing rubbish that had been tested in pregnancy for the last 100 years. When I was a medical student, we got an estrogen level for women, and that was supposed to tell us whether they got preeclampsia. Useless, not directed at the biology of what's going on, a poor understanding of the disease process. So that business of us being able to understand the pathway for those placentas has been a really key part of saying this is a good test and why. What it's telling us, what can we do to enhance the healthy placental function. I've said the word placenta now 75 times, we'll keep going. And then, what are the good and bad factors? And then how can we measure those meaningfully that take some of the subjectivity away and gives clinicians around the world better, affordable, reliable tools that allow us to say, yeah, we can measure this and we can do something about it early on. Yeah.
And when a woman develops preeclampsia, does the problem go away when the baby's delivered, or does this predispose women to a higher risk of cardiovascular disease post-pregnancy, and if so, why?
Look, I'm ashamed to say when I first started practicing in this area, we commonly said to mums, I think we said to you, Amanda, it's all over, you've delivered your preeclampsia baby, it's done, go off and have a happy life. And then we started to see some things again as clinicians that worried us, and I think one of our 5-year-olds found mum dead in bed, of a sudden cardiac death, and we thought, what is going on here? Jane Tour, who works in our laboratory, went back and interrogated some very interesting New South Wales-wide data, 80,000 women who had responded in the 45 and up study, and we found that women who had any blood pressure in their pregnancy, but particularly preeclampsia, were getting their hypertension at 45, not 55 years of age. They were getting their strokes, their coronary artery disease, their cardiovascular disease, their peripheral vascular disease. They were getting those things a decade earlier than women who had a normal pregnancy outcome. That begs the question, did preeclampsia do something to them, or did they have the risk factors for that anyway? Were they women who got preeclampsia as one of their cardiovascular diseases? They could have had a heart attack anyway, but the preeclampsia indicated that they were on that pathway. It probably showed both things, that the preeclampsia has the impact on your body of having smoked for 5 years. So it damages the blood vessels irrevocably and puts you on a pathway that's a more rapid pathway towards cardiovascular disease. That doesn't mean that we don't look for those other risk factors. I know we use that term, but we try to identify why some parts of the population have more common rates of cardiovascular disease, and unfortunately that happens to our patients with diabetes, it happens to our patients with high cholesterol levels, it happens to our patients who smoke, and allows us to give with those women the advice that let's see if we can prevent the preeclampsia, but if you have had it, you've got an identifiable risk factor here that will change your trajectory forever. Let's invoke other very proactive strategies around exercise and yoga and diet. We've just been involved with the BP squared study across Sydney, which has randomised women to either have yoga or dietary advice or exercise or come and see me. One of the arms was you had to go and see Annemarie. Can we change the trajectory to their cardiovascular disease over the next 2 to 5 years by early intervention? So it doesn't go away. I guess we can ask Amanda later, but scary to know that it might not have been forever gone.
It is now. At the time, I didn't know.
No.
I thought it was done and dusted, but we've found now that it is a problem. So yeah. So you've got to get that cholesterol book out, get the cholesterol down, and do all the things that you're supposed to be doing.
Yeah. And how are you finding that it's presenting for you now in terms of a
I'm pretty good now.
Yeah.
No, I'm pretty good now. My blood pressure's perfect. Professor tells me. But I've you just got to really lose that excess weight and do the exercise, go to the gym, do all the things you're supposed to do. Don't smoke.
And having the awareness to monitor over time. Yeah.
But it certainly made us feel like we're well and truly at home at the HRA, isn't it?
Yes.
So you mentioned early intervention. Ideally, what are you hoping to change in terms of how we best diagnose, treat and prevent, both in the immediate term and then in the longer term?
Yeah, look, I think we've done a really good job, we being lots of people around the planet, of trying to identify very early in pregnancy which pathway to get on. Because we want to be able to say, your mums, that this trajectory for you is going to be pretty straightforward. you may only need to come 4 or 5 times, and some women want that. Other women want to be seen much more regularly, and we've done the kinds of studies that will help women here. Deepika Rajkumar study that Amanda and our team have funded recently is looking at remote blood pressure monitoring and whether having a blood pressure machine at home, not just that gives you terrifying results that you don't understand, but it's got a traffic light on it. Green light, stay home. Orange light, ring someone. Red light, go to the hospital straight away. So those systems are out there. We have found with that study that the preliminary results are coming off. Look, I won't give it too much away, but it works, and women find it really helpful to have better information on their devices. So that's just one example of ways that we can intervene through the pregnancy to make that as positive an experience, as much of an experience that you've got some control over as you can, but also that you feel some control and interaction with the system and not over-treat it. But I think more importantly, we're still seeing those emergent cases, you know, where something terrible is going to happen, and how do we get ahead of that curve? We would say in our world, how do we get on the top of the cliff and not wait till we're catching people at the bottom of the cliff? How do we see that they're walking towards that edge? And I do think that a broader potential application of our blood test that we indicated is helpful. But one of the other main arms of our work has been to seek treatment that's cheap and available. And we started working on RNA therapies. Now, if I'd have said that to you pre-COVID, you would have thought, what are you talking about? But now, yeah, all know Moderna was an RNA therapy. And in fact, some of our data fed forward into the Moderna vaccine development because we, like lots of people around the world, have been working on RNA therapies for a while. I think we've got a slide up there of Mel Moore, maybe if we go back one. So the RNA, maybe one before that as well. The RNA therapy team at University of Massachusetts, in the top slide there is Melissa Moore, who sold her patent to Moderna for I think about $100 million. She had preeclampsia, and she was determined to think about how she could use her lab skills and talk to people that knew us, and we got involved in the team that started to do RNA development that targeted soluble FLAT1. So it specifically turned off the toxin. Now the theory is that if you make lots of toxin, you make it go away, you'd be better, but could you turn it off too much? How much do you need to regulate it? So that's the first time I got to visit the Gates Foundation in Seattle, who thought our ideas were good ideas and wanted to back in our funding. That was one of those pinch me moments in my scientific career, going to the Gates Foundation and some of our work. And that led to the most recent, recently completed as well, but $2 million grant that we got from the NH and MRC here in Australia to look specifically at adaptation of RNA therapy, and we're still working on that. Some of our variations didn't work straight away, and we're back at the drawing board, but we think there's a future for that treatment. We were hoping to not refrigerate it, and that part of it didn't work in COVID, you know, refrigerated planes flying vaccines all over the world. We want a non-refrigerated $11 a dose version that lasts for 4 weeks. You take that, you can get from your remote village to somewhere that can offer you decent care, and at least then we may not always prevent it, but we can stop you dying from it. So that's the idea of the rescue therapy part of our work. Yeah,
it's terrific, and it's great to see that, you know, funding support. It really plays in.
Absolutely.
Yeah. Now you've got a very talented team that you work with. Would you like to introduce some of them and tell us about some of their work?
Yeah. So Angela's an apology. She got COVID. Couldn't even text me back tonight, so she apologises for not being here. Angela was a PhD student who came to work with me in 2002, around the time that Amanda and I met. And it's been one of our great passions in the work that we've been doing is to fund champions for the cause. I think Amanda said to me years ago, these PhD scholarships are a good thing, you know, they don't stop investigating preeclampsia. And I know. So we've now got leads in preeclampsia work and research at Campbelltown, at Blacktown Hospital, at Bankstown Hospital, at Fairfield Hospital, at Liverpool Hospital, at RPA. There were already established units at North Shore and at Westmead, but by extending our reach into Western Sydney, we look after 45 to 50,000 pregnant women every year with the team, and they are the women who can take our diagnosis, discoveries and use of the test and provide feedback into ways of researching and the things that they might be interested in. So Alison Canty at the top, there's a current midwife. In fact, she was on the phone to me tonight when you were trying to get my attention. We've got a grant going in at 5 o'clock tomorrow, there's a new bit of paper that we need and something that we're doing. She's looking at what makes women delay having the next baby and what is it about the decision making and what they're told about how long they have to wait. And I looked at my records fairly recently, and the women who have severe preeclampsia, only 50% of them ever have a second baby. So it actually turns them off trying again, which, if that's their dream to have more family, can be devastating for a family.
Just on that,
Yep.
is that because of the psychological impact of preeclampsia, or is it because of
You have to ask Alison in about 2.5 years'
Okay.
time. She'll be able to answer your
Great,
question.
okay.
But they're really great questions,
Yeah.
and that question would lead us down the pathway of a PhD. Alison's a career midwife. She's in her mid-50s. She's delivered many, many, many mums and is frustrated by not having the right information. So she's come to us and is working on that project. So I won't go through everybody, but Katrina, I mentioned, is the one who got her professorship last night. Renuka did a project, was the first person ever to look at blood levels of pregnant women who take aspirin. So we've been recommending these treatments for 50 years and no one had ever looked at pregnant women's blood levels to see how much they need to take to get the right blood levels. So her work's been published in major journals. She and I rewrote the Australian Pharmacy Guild guidelines about pregnancy and aspirin as a result of the scientific evidence of her work. So she's a fabulous researcher. John Hyatt was the Professor of Obstetrics and Gynecology here at the University of Sydney, recently has taken up a position in Liverpool because he can see that data being extended to a much broader crowd. I will draw attention to Memory Nagira, who's the lady there on my left, who is a midwife that I met when I was giving some talks in Malawi in Africa. And she said, why aren't we doing these things here? I said, I don't know why. Why don't you do them? She said, we need better evidence. What do you need? I need a local randomised controlled trial. I said, so let's do it. That was finished and accepted for publication in Hypertension 10 days ago. So we're now doing some work, in places that need us the most. And our theory there was that they had their own ideas, their own teams, and we build capacity. We just provide advice on how to do it. So I talk to her twice a week, have done for 5 years, and we've just received our first tranche of Gates funding for continuing clinical trial work in Malawi, and she'll lead that team. So look, yeah, great team, great birds.
Absolutely. And talk to us a little more about the international collaborations that you do have in place.
Yeah, look, that was totally serendipitous. But when I go into Africa, at least, the three big killers of women are infections, and they happen suddenly and can be very rapidly lethal if you haven't got access to the right antibiotics, for example. And we have great access to antibiotics, and we rarely see those deaths. The second tranche is bleeding, and the kind of places I visit in Africa don't have a blood bank, or they do, but they've got one bag of blood. We have access to blood products here, and we're also better at perhaps anticipating and fixing it. I raise those things simply because when you're in a very resource poor area, you can kind of only deal with one thing at a time. So I think government decisions over the decade I've been working there have been, well, let's go after sepsis first for a while and let's get on to bleeding second. They're up to preeclampsia. And because we've built a relationship with communities there over the last, now I've been going nearly 10 years, we were in the right place at the right time, although you make good luck happen, don't you really? But we were there ready with the built relationships, and we have been some of the go-to teams to help. There are others that are working in Malawi because the rates of death are so high. But when I give talks there, people phone in from Mozambique and from Tanzania and from Zambia, and there's lots of interest. In fact, for the visit I'm doing in a couple of weeks' time, they've asked me to go through Cape Town on the way to talk to a team from the Democratic Republic of Congo. I do speak a little French, so I'm going to try and make that work. But actually, that sphere of influence is to think about it and to ask the questions and how can we make that work. At the same time, realising that our skills that we can provide for them is what they are asking for, which is greater skills in evidence and conducting research and setting up their own laboratories, and the things that have been facilitated for us here at the HRI.
Terrific. And just some sort of broad questions now. Sure. What's the thing that you've discovered in your scientific career that has surprised or overwhelmed you the most, and why?
Yeah, look, I've always thought that being able to apply our research in everyday clinical practice is a very exciting moment. When someone rings me to say that we've been able to do this test, or we can't do the test in Toowoomba, can you do it for us, how do you do it? that brings great joy that the things have been meaningful and that the communities that we serve, you know, really want to know about it. I think being asked to provide information around the time of COVID was pretty amazing, and what that taught me about science is that it's just such a long game. And we didn't do it because we thought there was a pandemic coming, but this little group, you know, our group sitting here in our corner of the world in Australia, nodding away at bits of placenta in the back of the lab day by day, suddenly had information that was important, and that scientific discovery that saved, on my reckoning, 50 to 100 million lives over 2020, 2021, when those big, you know, runs of COVID were coming around, with nothing like the death rates that had been seen in other pandemics. And that comes from little teams of us doing really solid, good work as often as we can. So I think that was a pinch me moment.
Yeah, that's great. And I think that point around it being a long-term play is a really, really key one. Yeah. And what are your dreams and visions for your lab and for medical science more broadly in Australia and beyond?
I did challenge Katrina when she sent me this question, because it's just not the way that I see the world. I'm not here to make the lab better. I don't really care about that. What I care about is, you know, one less sick woman, one less baby that I have to bury seriously. The consequences of that for a family are just forever. And again, I had a phone call, I say last night, but I can show you my voice, it's true. So I had a mum that I looked after who lost her baby at term from preeclampsia. It shouldn't have happened, but it happened. And that was about now 12 years ago. And at the time that the baby died, 12, 13 years ago, at the time that the baby died, her other daughter was 3 or 4. And the impact of that baby loss on that family. Anyway, she rang me last night to say that her 3-year-old was now 16 and had her baby lost. In fact, she named the baby after me. So, it made me cry. But the impact on those families is what drives me every day and what gets me out of bed and makes us work with the families that are around us. And if the lab does a good job at that, then the lab will do a good job of it. It will be funded and will work. But I didn't come here to make the lab.
Sandra, I hear you nodding.
Oh,
Or
right
see you
there with
nodding.
you.
Yeah.
Thank you so much.
Now, what do you need most to make your dreams materialise?
Yeah, I've got the obvious answer is give us the money. But actually, I actually don't think that. Well, I had the privilege of working in the United States for a while, and it struck me that you can spend the money wrongly, inadvisedly, and you can be wasteful. I saw a lot of that. But they were still ready to do great things. That's using, again, the pandemic as an example. I'm not saying that great ideas don't come out of the States. What I loved about coming back to Australia and working here was how directed the research was. We have regular contact with the patients. We have great advocacy from the patient groups. We know the questions that they want us to answer. And I think good designed research is what I dream of. I do think that the bureaucracy is complex, but I think it's ever designed to protect the patients more. And I like in my leadership roles that I have, and I have a few of those, to be thinking about what is the reason behind those systems. But I think from an Australian perspective, if we had better data connectedness and we had better data systems, we could actually be more efficient about the way that we want to do things. And I'm not challenged by putting in grants all the time. I think it's really important that I'm able to formulate good plans, good ideas, workable plans that have got consumer advocacy support and that are doable within an environment that can make that happen. And part of the challenge is doing that. But let's not have that overwhelm the work, which is sometimes how it feels a little bit. So.
Okay, terrific. Well, we might open up for some questions now from the audience. Does anyone have any questions that they'd like to ask of Annemarie? And people online too, please feel free to log questions in the chat. Do we have a question?
No, I'll give a very long answer. Yeah.
Do you think we could ever, like approaching preeclampsia, do you think we could ever get the scientists, the international scientists, to do what happened in COVID and just set aside, you know, countries and all sorts of self-interest and actually solve a problem and save hundreds of millions of people?
Yeah, I do think that. So Amanda's question is, would we be able to get on top of it just if we made a worldwide effort for 18 months, could we make it go away? I think the thing is that we're not going to make it eradicated in the same way that we could eradicate the world of smallpox or something. I think it will always be there, but we can get better outcomes from the way we manage it. And I think some prevention strategies will keep the rate down, but nothing we've seen yet makes it go away. But could we find the thing that makes it go away, that turns a placenta on into a better growth? I think the answer is yes. But I think there's got to be a readiness to do that. So I recently had the privilege of looking at maternity services in Timor-Leste, and I thought it would be pretty straightforward from an antenatal care perspective to look at this condition, and it's pretty common. People hate it. The midwives are frightened of it. The mums are frightened of it. Let's get onto it. When I realised quite quickly, I was only there for 2 days, that 1 in 200 people have tuberculosis in that community, and it's right on our doorstep. Unfortunately, you're not going to like this, Amanda, but I'd say let's get on top of the TB first. You know, there were 50% of their intensive care units 5-year-olds with tuberculous meningitis. I mean, seriously, it's just a tablet. So I kind of think a bit like I've seen in my experience in Africa, get on top of some of the simple things as a worldwide effort. And the people who are in that world would say to you, you know, where's my dollar compared to your dollar? But I do think we're going to see, they're manageable problems that if we get behind them we could fix. But I'd like to think that this discussion in another 10 years' time will see what we're seeing already, which is a continual decrease in the maternal and baby deaths from preeclampsia.
Julianne.
There's hands up everywhere.
Oh,
That's all right. You mentioned about the long-term effects of preeclampsia on the woman. I wonder if you've got any comment about the impact on the baby and future risk of hypertension?
Yeah, but both the mother and the baby are at increased risk going forward. A lot of work was done because a lot of these babies are premature on developmental work and readiness for school, and that work's ongoing, but actually they're more likely to have higher blood pressure, even if it's at the margins by the time they're even 10 years of age. I mean, David Selmar is one of the researchers here, looked at premature babies' blood vessels, and they're born smaller like the baby is, but they actually don't grow as well. And so having your blood vessels born early can be bad for your blood vessel development. So it matters to both. I know I've focused a lot on the placenta and the mum, but yes, that's a great question. Thank you. Yeah. So we had a question up the front here.
Yes. Is
Yep.
there a predisposition to eclampsia? Genetic? How does it come about?
That's a great question. Is there a genetic predisposition? And the answer is a little bit. There's probably elements of your genetic code that give you a slight predisposition, but actually the earliest image of preeclampsia is a 6,000-year-old hieroglyphic on an Egyptian tomb. There's not a single race on the planet that doesn't get it, and the rates in every population on the planet vary from 4% to 12%, and that just depends on how many blood pressure machines they've got. I don't think the rate's genuinely different. I just think it's determined by how diligent you are about being able to determine whether it happened or not. Sometimes it only lasts for 12 hours, but it's there. So if you're at term and the baby slips out and you kind of get over it the next day, that's all good and well. But the detection parts of all of that are in play. Some communities, there was a study that looked at, just give you one example, a particular population, I think in Israel, and they found that a clotting factor defect genetically was linked. And that little population, I'm not saying that wasn't true for them, but when that was tested in dozens of other ethnic groups, it didn't pan out. So there's probably a number of little factors that contribute: clotting, cholesterol, we've talked about, blood pressure, genetic factors. And I have met families where it's been more than one member of the family, but for everyone I've met in that situation, I've met someone for whom it's out of the blue.
Katie?
Yeah, it was very much on those lines as well, just trying to find out if there was like cultural, racial prevalence and what did that, because you talked about, Palm Island to Timor-Leste to Africa, and like you just mentioned, Israel as well. So
yeah, it's everywhere. And I think our results for some of our remote Indigenous communities in Australia isn't as good as it should be. In fact, the maternal mortality and the baby difficulties are higher. That's a function of remoteness, failure to recognise the need to provide birthing services on country And I think there's an awareness of how that could be done better by, I think there's a big program down in Nowra, where there's a birthing centre that's been designed for, and with the local community that build trust, and we think that that's going to move the dial. But I wouldn't for a minute target that as a genetic or a racial trend. Andrew, yeah.
Can I ask, I mean, you clearly make a very good argument about identifying, monitoring and picking up high risk before it gets problems. Is there anything we could do at a whole population level that could reduce the risk for everyone and take everyone down a notch? And a related question is, reproductive health and care is under threat in many countries. Could that have an impact?
Oh, we're all terrified of what's going to come out of America now that Roe versus Wade. There's maternal deaths happening in America that didn't happen before that change in the law, and that's to do with reproductive care and reproductive health. So absolutely, policy settings matter. Done so well. No, it's good. I've just got in some countries, even though we're getting good outcomes in Australia, the rate is going up because of increasing rates of obesity, which track to hypertension and diabetes, in particular diabetes in pregnancy. So there's absolutely things we can do as a community to say that the healthier you are, the better in terms of timing. Alison and other people are looking at the work around interpregnancy interval and age at first pregnancy. So some of our work has looked at that long-term data about whether being younger or older when you have your baby is biologically helpful in terms of the risk of preeclampsia. We do see very high rates of very severe preeclampsia in our 14-year-olds, and we've gotten away from that problem by advocacy campaigns against, for example, teenage pregnancy. My oldest mum, who had her first baby, was 63. So I think having a baby at those extremes of age, without the awareness that the biological impact of that's going to be very dramatic on your cardiovascular system. So there's a number of factors there, lifestyle factors, age at pregnancy, choice. I think I can't imagine putting aspirin in the water. I don't want to do that. I don't know that that's that good, but communities that have low calcium in their diet have higher rates of preeclampsia. So access to appropriate dairy and calcium addition. In the African trial, we added calcium to all the mums, and that was 4 times the cost. Calcium tablet cost 4 times an aspirin tablet. So we were killed by the price. But better off if you can have some milk and cheese and a bit of tofu and a bit of parsley. Amanda, did you have one more?
I was going to say, but that's the question that we all ask, which is, what can we be doing? That's why we come back to, why can't we do the test once a month? We can get our blood pressure taken. If we can get the test done cheaply, why shouldn't we be doing that just universally to all pregnant women and predict who's going to get it?
And would that be cheaper to deliver and more objective than what we're doing at the moment? We don't know, actually. There's a couple of studies that tried to do that, haven't been convincing, but with the design faults in those studies, and that's an open question for us at the moment.
And
the cartridge test,
yes. I think you should talk about that.
Yeah, so if we just flick back to the slides, so this is the test now being able to be done not in a laboratory but done at the bedside. So if we can just go back on our slides to that one. So that was me with a group of midwives about 8 weeks ago in Africa, the first time we ever detected preeclampsia on a COVID-type cartridge in the field. So that was my hand holding the test, showing them that we can do it. So that, not just that the second stripe is there to say that you've got some of this toxin floating around, but this team that's funded by the Gates, which is the study we're currently doing there, is actually quantifying that test to tell us whether it meets 30 or 50 or 80, and it's the number that matters. And so I remember someone rang me this morning and said, "Oh, my COVID test is a bit weak." I said, "You still got COVID, mate." so don't come to work. But this is not, this has to be better than that. It has to tell us how much COVID you've got. So it's quantifying the bedside test reliably. And the very first one we did was a positive test. So if we can do it cheaply on a cassette, the plastic's quite expensive and they're quite heavy when you buy them in bulk. I mean, you've probably got a whole drawer full of COVID tests like me at home. What they're trying to do with the Gates people with us is to do that just on a bit of blotting paper, like with a heel prick test for a baby. So you'll have a strip of blotting paper and you can do, 1,000 women in a day for, like 1 cent or 2 cents a mum. So that's part of the ambition, is more subjective testing. There are those group of clinicians though who if we take that away from a chance to talk to mums about what they want and provide the pastoral care that they need, people like me want to do a bit of both. I think there's still an opportunity to hold your hand and say, what questions have you got for me? Yeah.
You'll still get that opportunity.
Yeah, there's plenty of that around. Terrific.
Any final questions? No? Well, thank you, Annemarie, so much, and thank you to you too, Amanda, for joining us tonight, and thank you everyone for making the time to join us. We hope you found it really interesting and informative. Please do let us know if there are any follow-up questions that might come to mind after. We'd be very happy to follow up and get answers back to you. There are lots of ways that you can support us. First up, if you've learnt something tonight that you found really interesting, please do share it. Raising awareness is really important. So if you can share the message with family and friends, please do so. Our social media handles are up there on screen as well, so please do follow and tag us in on anything that you're sharing so that we can be aware of it and comment and follow up with people for information as well. And of course, we'd love for you to talk to us about philanthropic funding so that we can further the great work that's being done by the research teams here at HRI. We are also in the process of bringing together a consumer group. So we would love to hear from anybody who has been or is impacted by cardiovascular disease, who would be interested in spending some time with us. Those groups will be very important in terms of informing our research projects and our work. So please do let us know. We anticipate that we'll be meeting quarterly, and we'd love you to be a part of those groups and contribute if you are willing and have the time to do so. So please stay tuned for more news of our next event. This will focus on atrial fibrillation and stroke, and will be delivered with Professor Ben Friedman. Before we finish up, I wanted to ask you, Annemarie, if you wanted to leave people here tonight with one final comment, thought, point to consider, what would that be?
Well, thank you. I think the education is really important, and I commonly have a reputation for being the person who says at the end of every meeting, what did you learn? So I would go away with something that you can tell me. So someone tell me what you learned today, and that will be what I'll walk away with.
Oh, I've learned so much today. What have I learned? What I'm all. For me, it's just all about the funding. I was wondering about the outreach, so I was interested in the philanthropic. You were talking about all the time you spend writing these huge applications for grants. I would really like to make that happen.
I spend 17 weeks a year writing grants.
So it's all about outreach, isn't it? So that's the part that I'm.
I think that's a great point, Sandra. And yeah, none of this amazing work can be done in absence of funding. So thank you for making that point.
Thanks, everyone.
Thank you everyone again for joining us, and hope you enjoy the rest of your evening.
Thank you.